My name is Douwe van der Heide, and I'm a psychiatrist from the Netherlands, and I'm going to talk to you about psychosis as a confounder in symptom credibility testing in refugee mental health. As you are well aware, I suppose, psychiatric morbidity among asylum seekers and refugees is high, although the symptom validity of these data has hardly ever been assessed, so is virtually unknown. I used to work as a psychiatrist in a referral center for refugee mental health in the Netherlands, a clinic with 32 beds and mainly therapy-resistant cases. And at some point I was asked to introduce routine outcome monitoring in this setting, which was quite a challenge, because so far we only used open interviews. At that time, I was very interested in a particular symptom called the mirror sign. And through open interviews, I had established that about 35% of my clinic population was reporting this symptom. When I started introducing standard questionnaires for routine outcome monitoring, I selected the dissociative experiences scale as the mirror sign is one of its items. And lo and behold, I found a similar prevalence rate with this instrument as well. Moreover, the DES scores in our clinic population were actually quite comparable to what we found in other research, in other psychiatric admission wards. So that was quite promising. However, we did an additional test into the symptom validity of our findings by using a self-report validity test called the Structured Inventory of Malingering Symptomatology, the SIMS, to which we also added the mirror sign as an extra item. And actually we found a comparable prevalence rate in this way as well. However, as you may know, self-report validity tests like the SIMS are actually questionnaires with symptoms that are either rare or very unlikely. At some of the items of the SIMS, we found a comparable prevalence rate. For example, the item, when I'm hearing voices, it's like my teeth are leaving my mouth. We found a prevalence rate of 32%, which is indicating a very poor symptom validity, actually. Now, at the time, we did think that intentional overreporting was the main explanatory factor for this finding. We actually thought that it was the fact that we had to use dialogue interpreters to assist us with the testing that it was the main explanatory factor of poor outcome in symptom validity. So instead, we introduced an instrument with a much smaller verbal mediation, Morel's emotional numbing test, which is actually a performance validity test, a emotion recognition test with a minimal cognitive load and only 10 emotion words, which we could easily have translated and back translated before we introduced the instrument in the clinic. In addition, we still used professional interpreters with this test, as some of the patients reported that they were not able to read or write. And we did find less devastating findings as to symptom validity with this instrument, whereas 81% of the patients in the clinic failed the SIMS. Only 61% failed Morel's emotional numbing test. And by failing, of course, I mean that test score was higher than a pre-established cutoff for Dutch patients. So it was a bit of a better outcome, but still still indicating a very poor symptom validity. So we started looking for other factors as well. And for this reason, we looked at our DES data again, and we made an analysis differentiating between patients with a refugee status and those without a refugee status. When you have a refugee status in the Netherlands, you also have a residence permit, so it's quite important for our patients. And we found that patients with a refugee status and a residence permit were reporting significantly less dissociative symptoms than the other patients. So being in procedure for asylum, still not having a refugee status, is a main factor explaining the level of symptom validity. So I asked the social workers of our clinic to screen the medical files of our patients for procedures that might affect their symptom reporting behavior. And we came up with 3 groups. One group with a so-called positive incentive involved in a procedure that might be an incentive to exaggerate symptoms, for instance, an asylum procedure, and a group with a so-called negative incentive involved in a procedure that might be an incentive to deny or minimize symptoms, for example, a compulsory admission, and a middle group with no or mixed incentives. And if we look at the DES data again in this way, we see that the patients who were involved in a procedure that might be an incentive to exaggerate symptoms are actually reporting much more dissociative symptoms than the other groups. And the same is true for the reporting of rare or unlikely symptoms, as in the SIMS. And it's also true for error scores on the Morel's emotional numbing test. So being involved in certain procedures does make a difference as to symptom validity as well. Now, as you might remember, I was asked to introduce a standard questionnaires as a routine outcome monitoring instrument in our clinic population. So at some point, I started to do Morel's emotional numbing test, not only at admission, but also at discharge. And here you see a selection of patients that passed a Morel's emotional numbing test at admission in the blue columns, and in the green columns you see the same patients and their error scores towards discharge. And as you can see, once again, you see that patients with a positive incentive are making much more errors towards discharge than they did at admission. And what I like to demonstrate is that even if you control in this way for the effects of differences in culture and language as a confounding factor, you still see a strong effect of procedures. However, being involved in a certain procedure is not the only explanatory factor of poor symptom validity, because if we look at the failure rates of our patients in the negative incentive sample, we still see that 21% of them fails Morel's emotional numbing test, makes more errors than the cutoff. Whereas our healthy controls, the interpreters that we also asked to do the same test, failed in only 2%. So there's a big difference there. There must be another factor. And the factor that we came up with was psychotic disorder, as almost all the patients with a negative incentive were classified with a psychotic disorder, whereas the other groups were classified in this way in much smaller numbers. So we started to compare patients with a psychotic disorder in the groups with no or negative incentive with patients with a non-psychotic disorder in the same samples. And we found that patients with a psychotic disorder, even without an incentive to exaggerate symptoms, were making more mistakes than their non-psychotic counterparts in the same sample. So a psychotic disorder does seem to be a factor. Actually, we started to introduce Morel's emotional numbing test in another ward as well, with only Dutch chronic psychotic patients. And as you can see, we found the same failure rate as in the asylum seekers and refugee patients in our negative incentive sample. So you see that psychosis is a contributory factor in poor symptom validity, although it's comparable to other groups. Failing symptom validity test means that there is a considerable diagnostic uncertainty. And one of the ethical principles that we like to adhere to is that you should avoid potentially harmful treatments with side effects in patients where you are uncertain about the diagnosis. So at some point we felt compelled to start tapering off the psychiatric medication in all patients who failed at least 2 different symptom validity tests in our clinic. And here you can see the effect on our yearly expenditure on psychiatric medication. And the quite stunning finding that we had was that whether you spend 18,000 euro a year on medication or 3,000, it doesn't matter. There is no effect on symptom severity. So our a bit disappointing conclusion must be that all these years we have medicated patients that actually didn't benefit from this medication, but were probably harmed by its side effects. So my take-home messages of today are, in the first place, that in refugee mental health, in certain selected groups, symptom validity may actually be rather poor. Whereas our research findings indicate that the confounding effects of language and culture may actually be overrated at the moment. Whereas the confounding effects of psychosis are there, certainly, but they are comparable to other groups. And my last take-home message is that symptom validity testing may still be important in refugee mental health patients, as well as in these groups as well. It may prevent a lot of unnecessary treatment and therefore a lot of damage by unnecessary side effects. Thank you very much. I'd like to stop at this point and open the floor for questions. I'll try to see if I can stop this recording, which is not so easy. Here. Thank you.